pulmonary system, this is chapter 21, normal anatomy and physiology, part 1. Intrapleural pressure is negative. That negative pressure keeps the lungs inflated. The diaphragm does 80% of the breathing. It is innervated by the phrenic nerve, a branch of the fourth cervical nerve. The spinal cord damage at the level of C3 to C5 will alter breathing because it will affect your phrenic nerve. Exhalation itself is passive. Accessory muscles that are used are your scalene, your anterior serratus, and your sternocleidomastoid, just in case you forgot that. Your trapezius and pectoralis major are of the back are also accessory muscles, and for inhalation, for when you breathe in, your external intercostals can be an additional muscle. The purpose of the upper airways is to warm, filter, and humidify the air. The trachea is located below the level of the angle of Lewy at the level of the fifth thoracic vertebrae. The bronchus to the bronchioles are considered dead space, and in dead space there is no effective gas exchange. The terminal bronchioles do allow for minimal gas exchange. Your defense mechanisms: mucus produces 100 milliliters per day of mucus, all of which, except 10 milliliters, is absorbed. Its purpose is to trap foreign bodies. The right bronchus is larger than the left, and the angle of the right bronchus is less than that of the left, so it's very easy for foreign bodies to enter into that right bronchus. Cilia move those trapped particles toward the mouth and the nose. Where we cough, hopefully cough out rather than cough up and then swallow the mucus that is there. We also have alveolar macrophages, which phagocytize particles in the alveoli. Now, the alveoli we have are the major site of gas exchange. We have over 300 million alveoli. There are two types of cells. Type 1 cells are sensitive to toxins. That's about 90% of all the cells. They allow air to bypass the blocked alveoli through collateral air passages. Type 2 produce surfactant. This is 10% of the cells. They decrease the surface tension, they decrease the work of breathing, and they increase lung compliance. So they're very, very necessary. Approximate oxygen flows, by nasal cannula, 1 liter is 24%. Room air is 21%. So room air, you start O2 at 1 liter, you add 3, you get 24. Thereafter, you add 4% for each liter of oxygen flow. So 2 liters is 28, 3 liters 32, 4 liters 36, 5 liters 40, 6 liters 44%. If you need to do more than that, you go to a face mask. And with a face mask, 5 to 6 liters is 40%, 6 to 7 liters is 50%, 7 to 8 liters is 60%. Now, they do have a new type of oxygen out there, a vapotherm, that you can give by cannula, and you can give up to 100% O2 by nasal cannula. They were having a little problem with it. I think Toledo Hospital still uses it. The different measurements. You've got your pulmonary artery systolic pressure, which averages 25 millimeters of mercury. You have your pulmonary artery diastolic pressure, which is 10 millimeters of mercury normally. Your pulmonary artery mean pressure, which is 15 millimeters of mercury. Your oxygen saturation venous is 75%, and arterial is 96%, because you remember those lovely little thespian veins of the cardiovascular system, allowing some venous blood to get into the left atrium, so that the oxygen saturation there is decreased to 96% from being 100%. Your tidal volume is your inspiration and expiration. Your inspiratory reserve volume is that over and above. Your expiratory reserve volume is that is over and above. Your ventilation should equal perfusion, but close. Now, they should each have a dot on top of them, but I can't find that on my computer, so pretend there's a dot on top of the V and the Q. Ventilation is about 4 liters per minute. Perfusion is about 5 liters per minute. So your ratio is 4 to 5 or 0.8. Gravity will alter ventilation. So there's more ventilation at the base of the lungs than at the apex. Your pulmonary blood vessels will constrict if your PaO2 is less than 60. If your PaO2 is less than 60, your blood vessels will dilate everywhere except the lungs. So that is why you get pulmonary hypertension in your patients who have chronic lung disease, who chronically have PaO2s less than 60. Control of respiration. You've got your brainstem, which is automatic. The medulla takes care of the rhythm, and the pons the rate and the pattern of respirations. It stops inhalation and it controls the depth of respiration. Your cerebral cortex is your voluntary control. This is necessary because we laugh, we sneeze, we cough, whatever. And so you need to be able to control your respirations during that time. Central chemoreceptors are central to the brain, so these are located near the medulla. They sense changes in your hydrogen ion concentration, your PaCO2 in the cerebral spinal fluid. So if that goes up, they will increase respirations. This is a long-term effect. It doesn't happen immediately. Your peripheral chemoreceptors, on the other hand, sense changes in both oxygen and your PaCO2. These are located near, because they're peripheral to the brain, so they're located near the aortic arch and the common carotids. They sense a decreased O2 level and will increase ventilations. If you have an increase in PaCO2, they will also increase ventilation. Now, if you have somebody who has COPD, the body's used to the PaCO2, it will only respond to changes in your PaO2. We also have irritant receptors, which will help you cough, stretch receptors, which will protect against overinflation. Oxygenation. Your PaO2 is that which is dissolved in plasma. This is 3% of the total. Yet that which is bound to your hemoglobin is your SaO2 or SpO2, depending upon what you're reading. This is the majority of the oxygen. Your oxyhemoglobin dissociation curve, try saying that 3 times quickly, determines how and when oxygen is released from the hemoglobin. A shift to the right means that you have decreased oxygen bound to the hemoglobin. You have more available for the tissues, and this is what you want. This is a good or desired effect. When it shifts to the left, you have an increased amount of oxygen bound to the hemoglobin, so you have increased oxygen saturation, a decrease in oxygen to the tissues, and this is not a good effect. This is not what you want to happen. Now, page 570 shows a figure that shows the oxyhemoglobin dissociation curve, and hopefully we'll go into a little bit more detail there for you. But some of the things that affect this are changes in the following. If your pH is increased, it causes a shift to the right, decrease in oxygen with hemoglobin, and an increased amount of oxygen in the tissues. So if you have a decrease in pH, but everything else is increased, you have a shift to the right, and it's better for the body. That's why we no longer give bicarb routinely for patients who are resting. We used to do it every 5 minutes regardless. We now wait until their pH is less than 7.1 or less. If they're the PaCO2, no, if you have an increase in pH and a decrease in everything else, the PaCO2, temperature, and 2,3 dpg, you'll have a shift to the left, and you'll have increased oxygen with the hemoglobin and decreased oxygen to the tissues. Alkalosis is harder for the tissues to get any oxygen. (2,3 dpg) alters the affinity of the hemoglobin for oxygen. It's increased with hyperthyroidism, anemia, congestive heart failure, right to left shunts, and high altitudes. It's decreased with hypothyroidism, blood bank blood, and alkalemia, and septic shock. And these things will alter your oxyhemoglobin dissociation curve. If you have a decreased oxygen carrying capacity of the hemoglobin, this will occur with anemia because you don't have enough hemoglobin. If you have hemoglobin S, which is your sickle cell anemia, So you'll have a decreased oxygen affinity for the hemoglobin. If you have carbon monoxide or iron, which is methemoglobin, both of these have an increased affinity for hemoglobin so that there's no room for oxygen on that cell. On assessment, your history you'll find on pages 574, questions to ask. Inspection, you want to look at the tongue and the sublingual area for central cyanosis. We've already talked about this with the cardiovascular system. Fingers and toes for the peripheral cyanosis. Chest wall configuration. Excaviatum, you'll have a pectus excaviatum, you have a funnel chest, so you have a decrease in your anterior posterior diameter. And then if anybody ever watched Jay Leno, they had a college student who showed how he could eat his cereal out of his chest because he had pectus excaviatum. Pectus carionatum is a pigeon breast, so you have an increase in your anterior posterior diameter. You may have a barrel chest, which occurs with COPD, again an increase in your anterior posterior diameter. You may have some spinal deformities that will affect the ability for the lungs to expand, such as kyphosis, lordosis, and scoliosis. Think about leaning forward and twisting to the side where you have kyphoscoliosis and then taking a deep breath. You'll find out that it's not easy to do. Your respiratory effort. Remember that your normal respirations are 12 to 20. That's your goal, regardless of what your patient's problem is. If they have COPD, you're never going to reach your goal, but it's something that you try and shoot for. Tachypnea then is anything over the rate of 20. It's an increase in rate and a decrease in depth. Hyperventilation is an increase in rate and depth. The accessory muscles that they're using, we already talked about those. Is there any nasal flaring? Do the nares flare out? Do they have intercostal retractions trying to get more oxygen in? Do they have an unequal chest movement? There's a figure on page 577 that shows that. Do they have a tracheal deviation? Any tubes in place? There's a figure on page 576 that shows the different respiratory patterns that someone may have. Palpation of the trachea, there's a figure on page 577 that shows about doing that. Is it midline or is it deviated? Atelectasis will deviate to the side of the problem, and so will fibrosis to the side of the problem. Pneumonia, pneumothorax, and effusion will deviate to the opposite side. Thoracic expansion. Is it symmetrical or asymmetric? In order to determine this, you need to put their hands on their chest and check for equal movement. You should notice that your thumbs separate by 3 to 5 centimeters on deep inspiration. If it's asymmetric, this tends to occur with pneumothorax or pneumonia. Tactile fremitus. You'll see the text in the textbook, page 577. You'll find the technique for assessing for tactile fremitus. But you put the palms on the chest and you have them say 99. Normally it's decreased over the trachea peripherally. You'll find it decreased with effusion, pleural effusion, bronchial obstruction, pneumothorax, emphysema. It will be increased with pneumonia, cancer, and fibrosis. Percussion. There is a table on page 578 that shows the different tones and conditions that you'll find out for percussion. Diaphragmatic excursion is normally 3 to 5 centimeters, and it's inspiration minus expiration. But some of the tones that you'll hear will be like resonance, which is normal, or there with bronchitis. Hyperresonance, which occurs with asthma, emphysema, or pneumothorax. Tympany, like a drum, with a large pneumothorax or blebs that are due to emphysema, because there's a lot of airspace then. Dullness, atelectasis, effusion, pulmonary edema, masses. And flatness, which occurs with a pneumonectomy or massive atelectasis. Auscultation, there's a table, page 579 for your normal sounds and 580 for your abnormal sounds. Now, your adventitious or abnormal sounds can be absent, which is not good because then you don't have anybody having any air exchange. They can be diminished, which means that they're softer, so there's probably a problem with fluid or a mass of some sort. They can be displaced, where you hear your bronchial sounds in the periphery rather than over the trachea, and that's usually fluid or exudate. You can have crackles, which used to be called rails, but now they're called crackles. Inspiration, more so than expiration, and they can be graded as fine, medium, or coarse. Rhonchi, audible on expiration. They tend to clear with a cough and can be sonorous. So if you can't tell whether they're crackles or rhonchi, have them take a deep breath in and cough. And if it was a rhonchi, they will be gone or greatly decreased. Normal breath sounds are your vesicular, bronchovesicular, or bronchial. A wheeze is a whistling sound, or a whistle, and a friction rub is a harsh sound of like two pieces of leather rubbing together, and you tell whether it's pleural or pericardial by having the patient hold their breath. If it disappears when they hold their breath, it was pleural. There is a table on page 582 to 589 that lists the assessment findings of common pulmonary disorders with their different lung sounds. Your voice sounds help to identify consolidation or lung compression. There are different types. Bronchophony is when you have the patient say 99. And when you listen with the stethoscope, normally you wouldn't be able to understand 99. If they have bronchophony, the number will be increased in intensity and clarity, and you will be distinct, clear, and loud, because normally it's muffled. I don't know about you, but every time I put a stethoscope in my ears is when my patient wants to talk to me. Can never understand a thing with it with a stethoscope in my ears. That's normal. With bronchophony, I would understand. That would be abnormal. Whispering pectoriloquy is when you have them whisper 1, 2, 3, and you understand it. Egophony is when you have them say E, and it will increase in intensity, and it will sound like an A. There's a table on page 582 to 589 that again lists those sounds with the associated lung conditions. And we're going to stop part 1 here and continue with part 2 in just a bit.